Good morning, everyone. Thank you for the nice introduction, and I would like also to thank the organizer for the invitation. So I'll try to give you this morning an overview on the management of our hepatitis C and with some aspect regarding patients with hemophilia. As you know, hepatitis C virus infection is a major public problem worldwide. There are more than 170 million carriers of the virus, and it is especially a public health problem in patients with hereditary bleeding disorders because it is transmitted by blood and blood products. Another important feature of the epidemiology of HCV infection is the fact that hepatitis C virus is a variable virus which leads to genotype distribution. And here you have a distribution on the world map showing you that depending on the countries and the region of the world, different genotypes may be more prevalent, and we have genotypes 1 to 6. And this is something that has some major treatment implications that we will see later on during the talk. And the second important clinical aspect is the fact that 70% to 80% of the patients that have been exposed to HCV infection will develop a chronic infection, which is characterized by the persistence of HCV RNA in the blood and ALT elevation, which may be fluctuating over time. And this is also one aspect that is important to take into consideration because ALT may become normal at some stage of the disease and may reactivate later on. So ALT is not a good surrogate marker for the screening of HCV infection, which should rely on anti-HCV antibody detection and HCV RNA detection. So what are the clinical consequences of hepatitis C? Those that are linked to the liver. So patients may suffer from acute hepatitis, chronic hepatitis, and then the complication of chronic hepatitis, cirrhosis, and hepatocellular carcinoma. There are also extrahepatic manifestations of the disease, mainly via cryoglobulinemia, which may result in vasculitis and B-cell lymphoma or other autoimmune disorders, which may be the first sign of the disease, and patients may come to see their doctor first for an extrahepatic manifestation of the disease. There are also many other symptoms associated with hepatitis C, with chronic fatigue, impaired quality of life, and many patients also suffer from depression. As clinicians, we also, for patients' sake, we are interested in knowing the progression of the disease. And the rate of progression of the disease has been evaluated in cohort of infected patients that were infected mainly by blood transfusion when you really know the date of the transmission. And it was shown in most of these cohorts that it takes approximately 30 years to develop cirrhosis in patients. And once cirrhosis is there, the disease can be complicated by severe event, the development of hepatocellular carcinoma in approximately 3% of patients per year at the stage of cirrhosis, decompensation of the cirrhosis in 5% of patients per year, and liver mortality is approximately 2 to 5% per year. So this is the average, but it was shown also from the different cohort studies that some patients may evolve more slowly and will develop liver cirrhosis in more than 30 years, or in some patients will never develop liver cirrhosis and they are called to have a minimal disease. On the other hand, there are some patients who evolve very rapidly in less than 10 years towards cirrhosis. And there were several studies that showed that there are factors associated with a more rapid progression of the disease, which is the age at infection. When you're infected at older age, you are exposed to a more rapid disease progression rate. There are also host genetic factors, and it was shown that several polymorphisms in different genes may affect the disease outcome. Alcohol intake is also very important and should be taken into consideration when we manage patients. And also viral co-infections with HIV and HPV, which clearly worsen the natural history of the disease. So here you see how we assess the typically disease severity after liver biopsy. So there is the activity grade, which is inflammation in the liver, that is ranked from A0, no activity, to A3, severe activity, and fibrosis stage, which is a consequence of the inflammatory activity, which is ranked from F0, no fibrosis, to F4, cirrhosis. And you see here pictures of liver biopsy staining showing the progression from F1 to F4 fibrosis. Usually treatment indication is taken when fibrosis is equal or higher than 1, or activity is equal or higher than 1. Obviously, you all know that here there are problems associated with liver biopsy, and here I'm just showing you data from patients without clotting disorder. And since this is an invasive procedure, the morbidity is approximately 0.3 to 0.6%. Mortality after liver biopsy goes up to 0.5% of patients undergoing liver biopsy. This is one of the aspects which is obvious for patients with hemophilia or other clotting disorder, but there is also another important aspect, is the fact that with biopsy you can have false negative results, as you can see on the bottom panel, patients with liver cirrhosis, with regenerative nodules, and you see that on the right-hand side, that if the liver biopsy is taken in a regenerative nodule, the diagnosis made by the pathologist can be a normal liver. So in approximately 25% of cases with cirrhosis, the liver biopsy can lead to false negative results. So all these factors explain that there was a lot of research and effort made since the last 10 years to develop non-invasive markers. I'm just showing you one example, which is the use of FibroTest, which is very popular in France. But as I mentioned here on the slide, there are other tests like Fibrometer, the APRI score, ELF score, and so on. Here's just to give you a take-home message, an example on how to use these biomarkers. These biomarkers are quite simple. They use standardized markers like alpha-2 macroglobulin, bilirubin, gamma-GT, APO, LiPo, A1, and aptoglobin, which reflect the fibrosis activity in the liver as a consequence of the liver injury made by the virus. So it was shown by the group of Thierry Poinard here in Paris that there was a correlation between the FibroTest score and the fibrosis stage on the liver biopsy that you can see here. So you have a linear correlation that was shown in this first publication on 1,500 patients, and you see that it looks quite well, but with quite some overlaps between the different stages, and we will see that later on. The other technology beside biomarkers, and I told you that there are many other biomarkers that can be used, or scores that can be used. The other approach is the FibroScan, which measures the tissue elasticity, so the liver elasticity. And you see here it's a very simple procedure with an ultrasound apparatus, which is a little bit more sophisticated because you can measure this elasticity. It's non-invasive, it's rapid, 5 to 10 minutes. Can be done at the patient bed or at the patient's visit. You get rapid results, and the training is quite fast. If you are in a reference center, you need to practice for at least 100 examinations to be confident. Here you see the results, some studies that showed the diagnostic performance of FibroScan compared to liver histology. And here again, you see that you have a quite good correlation between the elasticity measured by the FibroScan and the fibrosis stage measured by the liver histology. Interestingly, you see here that the FibroScan seems to perform better for the diagnosis of F4 stages compared to the other stages. Then the obvious question was, can we combine the two approaches, a biomarker and the FibroScan? And here it was one study showing that the combination of two types of liver fibrosis analysis is better than the single one. So you see on the right panel, patients with fibrosis 4 on biopsy, and you see that the FibroTest performed well in 80% of patients with F4 the FibroScan in 90% of patients with F4, so better diagnostic accuracy for FibroScan. And when you combine both FibroScan and FibroTest, you have a confirmed diagnosis in 94% of patients. So you reach really a very good diagnosis accuracy. In patients on the lower end of the fibrosis stage, you see that it's a little bit more complex, and this is where you need to have a good accuracy, because this is where you have to take a treatment indication. And here on the left-hand side, you see that FibroTest alone is doing quite well, 80%. FibroScan a little bit less, 73% of concordance with a biopsy. And when you do both tests, again, you have a better accuracy. So that's now the current recommendation, is to use a biomarker and a FibroScan to have the best diagnosis accuracy. So here you have a proposed algorithm for the use of FibroScan and FibroTest. So you start with your HCV RNA that is positive, you do your FibroScan and FibroTest. If they are not in agreement, then the liver biopsy has to be performed. So it is, in your situation, it's very difficult, because you have to take into consideration all the side effects of biopsies in your patients with clotting disorder. And on the other hand, when it's easy situation, when both tests are in agreement, you don't have to do a liver biopsy. So now this is clearly recommended. No liver biopsy when the two tests are in agreement. When you have no or minimal fibrosis, so FibroScan less than 7 kilopascal and FibroTest less than F2, you can follow your patients and wait for more advanced treatment that we will see in a moment. And when you have moderate fibrosis, FibroTest equal 2 or FibroScan between 7 and 9.5, treatment indication has to be taken. And patients with severe fibrosis or cirrhosis, FibroScan higher than 9.5, FibroTest equal or higher to F3, then there is a treatment indication, but also indication for GI endoscopy to look for portal hypertension and ultrasound every 6 months to screen for hepatocellular carcinoma. So then when you have done this analysis, there is a treatment indication and treatment decision to take. Here is just a slide that summarizes the treatment objectives for 3 viruses that are very common in your patients. HIV, where you all know that since there is an integration of the proviral DNA in the host genome, we have to go and deal with lifelong suppression of our replication. There is no eradication. With HBV, with nucleoside analogs, we prevent viral replication and viral production, but there is a persistence of 2 forms of viral DNA, cccDNA and also integrated viral DNA in the host genome. So in this case, we also aim at long-term suppression of viral replication. For HCV, the situation is completely different, because there is no form of persistence of the viral genome in the infected cell. So the replication takes place in the cytoplasm of hepatocytes, and it is possible to achieve a definitive viral clearance and sustain virological response, SVR. So the situation is completely different, because we can cure the infection and the disease. Here it's a slide that summarizes the results that we have obtained in the last 20 years with interferon and ribavirin. And you see that on the left-hand side, 20 years ago, we were using standard interferon for 24 weeks, and the rate of SVR was very low, 5 to 10% maximum. And there was a major progress with the development of pegylated interferon and ribavirin, that you see the results on right-hand side, showing that for patients with genotype 2 or 3, we can achieve SVR in 80% of patients. And for patients with genotype 1, we can achieve SVR in 45% of patients. There were also 2 or 3 years ago major progress in understanding the role of host genetic in treatment response, and it was shown that the polymorphism of the interleukin-28B gene can predict the outcome of treatment in patients infected with genotype 1. Patients with a good polymorphism can achieve SVR in approximately 80% of cases, which is a major discovery at that time, but this was kind of short-lived because we have now new treatment that I'm going to show you in more detail. So you see here the prospect for the development of anti-HCV treatments. We have started with standard interferon for 24 weeks, very low rate of SVR, then improvement with pegylated interferon and ribavirin for 48 weeks, and optimization, individualization of treatment that allowed to really increase the treatment success rate. And now we are in the era of direct antivirals, and we are living now a real revolution in the field of anti-HCV treatment. And this was mainly the results of efforts made in the understanding of the HCV life cycle, and thanks to this basic research on the HCV virus, the crystal structure of most of the enzyme of the virus has been characterized and identified. Here I'm just showing you the crystal structure of the protease, the viral protease, helicase, and polymerase, and all the other proteins have also been crystallized, and their 3D structure is known now. And this has allowed to develop specific antivirals targeting these enzymes. One of the problems with HCV, as I told you in the introduction, it is a very variable virus, so at each replication cycle, there are mutations that are generated every day, and resistant mutants appear and are generated even in the absence of treatment, and they can be selected rapidly. They are selected rapidly and can emerge during antiviral treatment with a direct antiviral agent, DAA, in monotherapy. So what are the main HCV inhibitors, the direct-acting antivirals that we have? So the first generation of protease inhibitors have been approved, so telaprevir and boceprevir, and they are approved only for genotype 1 infected patients. Because they don't work on the other genotypes, they have some limited efficacy in patients with genotype 2 or 4, but you have to be very prudent there because there is no large clinical trials in these patients, but they don't work on genotype 3 at all. So there are second-generation protease inhibitors that are in clinical development, polymerase inhibitors, nucleosidic and non-nucleosidic, that can work also on other genotypes, NS5A inhibitors, entry inhibitors, immune modulators, targeting the innate responses or the adaptive responses. So there are more than 30 drugs that are in clinical development and clinical trials now. So how do we see the different strategies? At the current stage, we still have interferon and ribavirin as a backbone of treatment, and they are used in combination with protease inhibitors. But there are also, as I just told you, polymerase inhibitors, NS5A inhibitors, that really target the life cycles at different steps, and which makes sense for a true combination therapy. And the hope is to get rid of interferon and ribavirin in the future. So here you see what's happening in monotherapy with a direct antiviral agent. Here it was an example with telaprevir. You start treatment, you see viral load decline, and then after 2 weeks of treatment, viral load comes up again. And when you look at viral quasi-species, at baseline, the majority of the virus is wild type, and just after 2 weeks of treatment, you see that it's mainly composed of resistant mutants, and the wild type virus is becoming the minor species, very similar to what we knew for HIV, for instance. And when you stop treatment, then the wild-type virus starts to take over progressively because there is no selective pressure anymore. So clearly we cannot go for monotherapy with the drugs that we have currently now. But what can we do? It was very interesting that at that time, so 6 years ago, it was shown that in patients who were resistant to telaprevir after just 2 weeks of dosing, as you can see here, with a viremia level going to a plateau and selection of resistant mutants. When they were treated, they could be rescued by pegylated interferon and ribavirin because there was no cross-resistance. So this is a rationale for the triple therapy with a backbone of interferon, ribavirin plus a protease inhibitor. This has led to the approval of the triple therapy, and I'm going to show you the main results in patients infected with genotype 1, and here it's for naive patients who have never been treated. So you see really the efficacy of this triple therapy, because in a month, in 4 weeks, you see viremia levels going down by 5 to 6 log, something that we've never seen in patients treated with only interferon and ribavirin. When you look now at the sustained virologic response, so 6 months after withdrawal of the treatment in patients who received telaprevir plus peg-riba, in comparison with standard of care at that time, peg-riba for 48 weeks, you see that there are 30% more patients who achieve SVR. So this is really a major progress compared with what we had in the past. Now, if you look at the boceprevir-based triple therapy, again, the same thing, because you see that in the peg-riba arm, the SVR rate was a little bit lower, 38%, and it increased by 30% also with the triple therapy with boceprevir, reaching 66% in these patients. A very important point to help you manage these patients is that patients with an extended rapid virologic response, ERVR, which is defined by undetectable HCV RNA at week 4 and week 12, you see that you can achieve 90% SVR, which is remarkable. And the second important point is that in these patients with ERVR, you can decrease and shorten the treatment duration from 48 weeks to 24 weeks, which is really significant for patients in terms of side effects, as we will see later on. Another important factor when treating patients with triple therapy is the impact of liver fibrosis on the treatment outcome. And you see here the example of boceprevir, and it's the same more or less with telaprevir. In patients with no or minimal fibrosis, you see that you can achieve SVR in approximately 70% of patients. But when you treat patients with F3 or F4 fibrosis, it goes down to 52%. So clearly this advocates for early treatment intervention before patients have developed liver cirrhosis. So now this is really something very enthusiastic, very nice results in naive patients. So now we have many patients who have been already treated, who failed treatment. So what are the results of this triple therapy here? First of all, you need really to define what was the type of failure in your patients. Sometimes it's not easy because patients have been referred to you, they don't come directly, and so on. But it's very important to do this diagnosis of failure to the previous course of interferon and ribavirin. You have the classic patients who responded well and then relapsed. And in what we call the non-responders, you need to distinguish two categories. The partial responders who achieve at least 2 log decrease in viral load during therapy, and the null responders who usually didn't get below 1 log drop during therapy. And you will see that in terms of the results of triple therapy, this will make a difference. So really remember this and try to, when you see your patients, try to really make a good definition of this treatment failure. So here you see the results of triple therapy based on telaprevir. On the left-hand side, you have the prior relapsers. So you have extremely good results, 80 to 90% SVR. So patients who relapsed after peg-riba can be cured with the triple therapy. It's not the same for patients who were partial responders, and you see here you have approximately 50 to 60% of patients who will achieve SVR, and those who were null responders achieve SVR in only 30% of the cases. So you see the importance of your failure definition before starting triple therapy. What about boceprevir? Again, the same thing. You have a very good results in prior relapsers. 75% of patients achieve SVR. In prior partial responders, again, 40 to 50% of patients will achieve SVR, so that's good results, but not optimal. And in the prior null responders, they were excluded from the phase 3 clinical trials, the pivotal trials, but there are new studies, the results just came out recently, showing that the SVR rate is in the range of 30%. So you clearly see that null responders will be difficult population to treat even with triple therapy. Again, you see that here on this slide, the impact of liver fibrosis on treatment success in patients who previously failed to interferon ribavirin. Interestingly, in prior relapsers, there is no impact, which is very good. So it means that all your prior relapsers need to be treated with triple therapy. You will achieve a very high rate of SVR. In partial responders, you see the impact of fibrosis. Cirrhotic patients will respond in only 1/3 of the cases. In the null responders, this is even more striking. Only 14% of patients will respond, and there is almost no difference with the PEG-RIBA arm. So you have to be really take into consideration whether you're going to treat these patients with triple therapy or wait for something else. But these are the patients who are in need because they are cirrhotics and they already failed. So they are in danger of developing complications of their disease. Now, these were the results obtained in clinical trials, and I want to show you the results of the real-life patients. And this was here a cohort study that was sponsored by the French Early Access Programs and the ANRS, the National Agency for Research Against AIDS and Hepatitis. And this cohort is called QPIC. It enrolled patients infected with genotype 1, compensated cirrhosis, and they were non-responders defined for this cohort by relapsers and partial responders. Null responders were theoretically excluded because of their very low response rate. So they were treated in the French Early Access Program. It started in February, March last year. Here you see the treatment regimen. Since all patients were cirrhotics, they were treated for 48 weeks with 2 different regimens depending on whether they received boceprevir or telaprevir. And now we have the results of the week 16 treatment. I'm going to show you the preliminary safety findings for telaprevir. And this was really something that was surprising to us because we have managed patients within clinical trials, and here in the real life, this was completely different. You see serious adverse event in 50% of patients, death in 6 cases, so 2% of patients, so that's 6 out of almost 300 patients. Infection grade 3-4 in almost 10% of patients. Rash with telaprevir in 2 patients at grade 4 rash, so that to stop treatment. And almost 4 to 5% had hepatic decompensation during therapy. Anemia was extremely frequent in these patients. You see here approximately 10% had grade 3-4 anemia, EPO use in more than 50% of patients, and 15% of patients received blood transfusion. So this was really something that was surprising and that we have to manage now on a daily basis in our patients with liver cirrhosis who are treated with triple therapy. On the other hand, that's a good and optimistic results. The preliminary data at week 16 showed very good rate of undetectable HCV RNA in 86% of patients. Obviously, we are waiting for the SVR rate, but that we don't have so far. This will come in the near future. With boceprevir, also very high rate of serious adverse event, 40% of patients. You see premature discontinuation in 24% of patients, 2 deaths out of 160 patients. Again, infection, asthenia, hepatic decompensation in some patients. Anemia was also very frequent. You see here the rate, or 30% of patients had a hemoglobin less than 10 grams per deciliter. EPO use in 66% of patients, blood transfusion, 10% of patients. So this was really the striking result that we had from this cohort study. And the preliminary efficacy data for boceprevir were very good also, 70% of patients achieving undetectable HCV RNA at week 16. So now we have to wait for the SVR rate, but the management of these patients is really difficult. Cirrhotic patients have more side effects and mainly anemia that has to be managed with caution and in reference center mainly. So now to go to the last part of my presentation is, are we going to be able to develop interferon-free regimen? Because this is what patients and doctors want, as you've seen with all the side effects that we have seen. I will just show you some example to give you the rationale for that. Here it's a combination of two drugs from Boehringer Ingelheim. One is a protease inhibitor, a new generation molecule, and the other one is a polymerase inhibitor, a non-nuke. So they act at different sites of the virus life cycle. The resistance mutations selected by these two drugs are different because the one from the protease inhibitors are located in the protease domain of the virus, and the polymerase inhibitor select for mutants in the polymerase domain. So there is no cross-resistance between the two compounds, and it was shown in vitro in the replicon system in tissue culture, showing that when you combine the two drugs, you can achieve viral clearance. You can see that on the far right-hand side. There is no replication anymore when you have the combination of the two drugs at the maximal concentration. So you can really eradicate the virus from infected cells. So is it true in patients? So there was results from clinical trials, the first phase of the clinical trial that was just published recently. And you see on the right-hand side, when you combine the two drugs in patients, you can achieve viral suppression in these patients, in majority of these patients, after 24 weeks of treatment, and then they receive treatment with pegylated interferon and ribavirin to achieve SVR. And another very important study that was published at the beginning of the year by Analog showed the results of the use of two drugs, one NS5A inhibitor, daclastavir, and one NS3 inhibitor, azinaprevir, in patients who failed interferon and ribavirin. So these patients were already in treatment failure. So you see the results of the combination of the two drugs without interferon and ribavirin on the upper panel. And you see that some patients could achieve SVR, but they were only a minority, only 4 out of 10. And 6 out of 10 responded and then had a viral breakthrough or a relapse, as you see here on the top panel. But what was interesting is that on the lower panel, the combination of the two drugs plus interferon and ribavirin in a quadruple therapy regimen could achieve SVR in 10 out of 10 patients. So this was a major result showing that we can really think of, and not dream, really think of achieving SVR in patients who failed interferon ribavirin therapy in the past. And now the next step, and we hope it will be the final step, is a combination of all oral drugs without interferon and without ribavirin. And here it's results of a trial that was just presented 2 months ago at the EASL meeting in Barcelona, a combination of daclastavir and the NS5A inhibitor and nucleoside analog, an NS5B inhibitor, GS7977, with or without ribavirin. Here it was in treatment-naive patients, but they have also cohort in patients who already failed interferon and ribavirin. And here what is interesting in patients with genotype 1, but also 2 or 3. So you see different treatment regimen for 24 weeks only. And here you see the results. It's really incredible, although the number of patients still needs to be improved. We are in the first phase of the trials. We have only 15 patients per arm. But you see that the SVR at week 4 reaches 100%, which is really something remarkable. And this has been now shown with different combinations, different molecules, different companies, and so on. Here it was just examples as a take-home message that we will be able to achieve SVR with all oral combination regimen. Obviously, there are different questions to be solved, and that I'm going to go through now. The idea of a combination of DAA is to raise the barrier to resistance, so we prevent resistance to occur, to achieve the cure of infection, because this is what we want to aim at. And there is a very rapid clinical development, because now we can do trials in less than a year, because the treatment duration can be 6 months, 3 months, or even 2 months, and the SVR can be assessed only 1 or 3 months after, so you can go to the next phase. And this is really something very hopeful for patients. And we have now combinations that are genotype specific and some combinations that are pangenotypic. which is also something very hopeful for patients, especially genotype 2 or 3 patients who failed interferon or ribavirin, who had no treatment options so far. So remaining questions, the SVR after week 12, will it be maintained over time? So we will need to follow and monitor these patients. What will be the drug-drug interactions, especially in co-infected patients receiving antiretroviral agents? What will be the role of ribavirin? Because it seems that it increases the interferon-stimulated genes, which is something that can enhance the activity of the antiviral agents. What will be the role of interferon in patients with failure to interferon and ribavirin in the past? And also something that is very worrisome at this stage, what will be the strategy for patients who have failed triple therapy? Because we are treating patients now with triple therapy, and we don't have options for these patients when they fail. So to summarize the hepatitis C management, you need to screen your patients, all your patients. When they are HCV positive, you need to do genotype because it has a major impact on the current management and treatment decision. Do your fibrosis assessment with non-invasive markers, including FibroScan. Then you can take your treatment indication. If there is no treatment indications, follow-up is very important because you need to reevaluate the treatment indications. Patients may progress. There may be new treatment to propose. On the other hand, when there is clear treatment indications, at this stage, it depends on the genotype. Genotype 2, 3, you don't have too many options. It's interferon and ribavirin when you're treating these patients in the real life outside of clinical trials. In patients infected with genotype 1, you can propose triple therapy based on boceprevir or telaprevir. You can also ask the question whether you go for a PEG-RIBA in patients who have favorable IL-28B polymorphism. And to conclude, how we see the future of anti-HCV therapy is the following. You see that now we are in the era of new standard of care with triple therapy based on interferon and ribavirin protease inhibitor. We are already entering the new phase, which is very exciting. So we have now drugs in development that belong to the new generation of protease inhibitor plus polymerase inhibitor, NS5A inhibitor, ribavirin, interferon, with or without interferon. So now we have to see what is the best option depending also on the patient population. And I'm sure it will be different depending on the patient population. And the aim will be, in the end, to have 3 or 4 direct acting antivirals based on protease inhibitors, different polymerase inhibitor, nuke, non-nuke, and NS5A inhibitor, with the hope of getting rid of interferon and ribavirin. But I'm sure that in the next 5 years, we should achieve this aim of having a treatment for hepatitis C and a cure for hepatitis C without interferon. Thank you for your attention.